Hi, I'm Dr. Mariana de Oliveira Nunes. I am a research scholar at the Minneapolis Heart Institute Foundation. This is a case of a 44-year-old man with the primary diagnosis of repaired tetralogy of Fallot. He also has a history of Noonan syndrome, Diamond-Blackfan anemia, obstructive sleep apnea, and protein-losing enteropathy. His first intervention was a shunt procedure in his first year of life. At 5 years of age, he had a resection of an aneurysmal right ventricle outflow tract with a transannular patch and a VSD closure. Over the course of the next 12 years, he developed severe pulmonary and tricuspid insufficiency with right-sided heart failure. At 17 years of age, he underwent a tricuspid plasty and an implantation of a pulmonary homograft. During the next 8 years, he progressed to RVOT obstruction and severe tricuspid insufficiency. At 24 years of age, he had another pulmonary homograft implanted and an implantation of a tricuspid bioprosthetic valve. This tricuspid valve progressed to moderate stenosis, and he required an implantation of a mechanical tricuspid valve by the age of 33. At age 44, he had increased symptoms of exertional intolerance, shortness of breath, weight gain, abdominal distension, and peripheral edema. He was then diagnosed with severe pulmonary stenosis and insufficiency. This is the echo that was done at age 44. His echo showed normal LV size with mild decrease of ejection fraction, severe left atrial enlargement, moderate to severe pulmonary insufficiency, right ventricle enlargement with moderate RV dysfunction and IVC dilation. In this video, we can see the pulmonary homograft and the severe PI. As you can see in this image, the echo also showed a thickened pulmonic valve with decreased excursion and a peak gradient of 49 millimeters of mercury. The patient had a cardiac MRI done in the same period that showed mild to moderate LV dysfunction, severe enlargement of the RV with still normal systolic function, and severe IVC and right atrial enlargement. Here is a video of a 4-chamber view where you can see the enlargement of the right side of the heart and the LV function compromised by invagination of the interventricular septum from right to left. The patient also had a CT done to better analyze the prostheses. It showed mild decreased LV dysfunction, enlargement of the RV, severe dilation of the IVC, coronary sinus, and right atrium, tricuspid prosthetic valve with normal valve angles and good function, and a 35% stroke volume difference that was assumed to be secondary to PI. This is a view of the heart, and as we scroll down, you can see the calcified pulmonary homograft, the enlargement of the right chambers, coronary sinus, and IVC, and the mechanical tricuspid valve. Another thing that I want you to notice is the intimate relation between the RV and the sternum. So what happened to this patient? Remember that he's a transfusion-dependent patient due to his anemia that requires IV diuretics after the blood transfusion for volume overload. However, in spite of not being back to his dry weight, the patient was discharged home early after the blood transfusion due to an upcoming holiday weekend. So 1 week later, he went to the ER with 20 pounds of weight gain and exacerbation of his back pain. A multidisciplinary case conference was held to discuss the next step. Because he had multiple previous cardiac surgeries, an open procedure would have high morbidity and mortality risk. But also remember that he has a mechanical tricuspid valve which impairs the usual transcatheter approach. So it was decided to do a hybrid procedure which was less risky option at the time. But what is a hybrid procedure? It combines cardiac surgery with an interventional approach. It's minimally invasive with a small incision instead of the traditional sternotomy. It is a valuable option for high-risk or reoperative patients. In this video, they're showing a hybrid approach to implant an aortic valve, so you can have an idea of how it's done. This technique used in the right side of the heart as performed in our patient is still new. So here in this video, they're showing the region of the heart where they're going to puncture to pass the catheter. So first, they're going to do a balloon valvoplasty, and then after, they're going to show the implantation of the valve. So a left thoracotomy was done with the exposure of the RV, which was punctured, and a catheter was inserted in the pulmonary artery. It was registered severe pulmonary insufficiency and a gradient of 35 millimeters of mercury across the pulmonic homograft. Here you can see the catheter inside the pulmonary artery and the PI. In the left-hand video, you can see the pulmonary balloon valvoplasty. In the right-hand video, you can see the deployment of a stent inside the homograft. This stent was implanted to anchor the transcatheter valve. On the left video, you can see the insertion of the sapien valve. The procedure occurred without complications, and on the right video, you see the result with no residual PI and a pulmonary gradient of 13 millimeters of mercury. The take-home messages that we want to pass to you are that patients with complex congenital heart disease usually go through several surgical interventions during their lives, and currently they have been living longer, so other comorbidities appear. Risks of multiple surgeries are high, and each patient is a different case, so you have to individualize the treatment. We also wanted to show the importance of different imaging diagnostic techniques in this group of patients and the challenge that it is to find a way to treat them. So a hybrid approach with a transcatheter procedure carried the less risk in this complex CHD patient. And we have to keep in our minds that a hybrid approach must be in our usual arsenal when treating this kind of patients. Thank you for your attention.